Hello, my name is Cynthia Malik, and I am here to give you a brief summary of the Psychiatry High Risk Program. I serve as a clinical psychotherapist here at the program, and I also am the Director of Admissions. To begin, I'd like to offer a history of the Psychiatry High Risk Program. We began here in 2017, and this was in response to a high level of community need for specialized treatment for youth and young adults with a high risk for suicide. We call our program PHRP for short, so I'll be using that. PHRP has an innovative recovery-based approach to suicide prevention, which has been shown to be highly effective. There are very few specialized treatment programs in the US for individuals with high suicide risk, and we have gained national attention through advanced publication of our outcomes in the leading journal of public psychiatry, Psychiatric Services. We have rapid growth and demand for our services, with patients traveling as far away as Georgia and Texas to attend. I wanted to present the difference between the chronic illness model and our model. So just a brief background, the chronic illness model is the predominant model in the US for suicide prevention. And in this model, depression, suicide risk, and impairment are expected to be long-term recurring problems. Individuals are expected to maintain a low level of functioning, have repeated suicidal crises, and have chronic waxing and waning of depression and anxiety. High-risk individuals most commonly receive multiple medications, crisis interventions, treatments, hospitalizations, and the such, just to maintain that low level of functioning. So this is not the model we use, but this is the predominant model of the chronic illness model. Some common misconceptions about recovery include the following, but are not exhaustive. Some statements will reflect these misconceptions and are congruent to that chronic illness perspective. I'll feel better if I can find better ways to block out my negative emotions and distract myself from what's going on around me. I'll have better relationships if I can do a better job at pretending to be someone I'm not. Finding a new medication is the main thing that's going to get me better. Finding a comfortable therapist to rely on for advice and support is what's going to get me better. Spelling out all my past trauma in therapy will remove its effects on me. So it's kind of that deluge or trauma narrative. And learning new coping skills is all that is required to get me better. So a lot of this is based on quick fixes or quick results. The recovery-based model, in contrast, which is our model, holds that individuals can ultimately recover and lead healthier and more fulfilling lives. We help individuals to make fundamental changes in how they process and cope with everyday emotion-laden experiences, which will change how they view themselves and others. The core treatment is called dynamic deconstructive psychotherapy. Family therapy is strongly encouraged, and which can include couples therapy, and group therapy is also available, but is optional and not required. Medications are added as indicated if a patient sees a medical provider here. Medications will not lead to recovery. Our model is not medication-based, but medications are seen as something that can assuage symptoms to a degree. Controlled medications, however, can be addictive in nature, even at a therapeutic dose, and can be disruptive to emotional processing centers of the brain, which we're trying to activate. So as a result, we do not prescribe controlled medications here at the Psychiatry High Risk Program. So information about our core model, which is dynamic deconstructive psychotherapy. This model involves weekly meetings with a therapist therapist who has been trained or has advanced competency in the model. After an initial 3 to 4 consultation sessions, it's determined if a person who's seeking services is appropriate for the services offered. And the duration is an entire year or 12 months of DBP in order to obtain the full benefit. 70 to 90% of people who complete treatment in the full 12-month course experience meaningful improvement in problem areas they came in with. Common diagnoses we treat include major depressive disorder, anxiety, borderline personality disorder, post-traumatic stress disorder, dissociation, substance use disorders, and eating disorders. Patients who benefit from weekly therapy are offered monthly maintenance treatment after completion of the full year. So how does DDP differ from other therapies? For one, the goal is not to improve symptoms or resolve crises. And the task is not giving advice or problem solving, teaching skills, or rehashing trauma. So this is different from the chronic illness model as well. The goal is, in fact, to strengthen a self-structure and lead to a transformative healing experience. Symptom improvement is just a side effect of this, but is not the focus. The task is to build self-capacity through exploration of everyday emotion-laden interactions. So being able to connect with your emotional experience, being able to express that is part of the core task, which helps you gain a greater sense of yourself and integration. Substantial research and evidence has been endorsed by SAMHSA and the Suicide Prevention Resource Center through SAMHSA regarding our program. So the research that is in place has been endorsed, and we have the stamp of approval by SAMHSA. Two core problem areas that are addressed in the theoretical model of DBP are emotional processing deficits and embedded badness. So anyone coming in with suicidal thoughts or risk is seen to have emotional processing deficits and not really having that full connection with the emotional experience, which is why it comes out in that suicidal thinking or gesture, and an embedded sense of badness or about themselves, which of course would make sense with that suicidal thinking or gesture. There are different parts of the brain that are activated through use of our model that are shown here. And this is a model of the brain. The two areas that I'll be discussing here today that have sort of that disconnect or misfire, you could say, are the amygdala and the ventral striatum. So the amygdala is the panic or fire alarm system of the brain, and the ventral striatum is the seeking part trying to put out that fire, and usually in destructive and impulsive ways with that disconnect. There's deficits in 3 self-capacities if you are looking at the DBP model that are meant to be addressed through therapy. Association is one of those areas, and association is the verbal representation, labeling and verbalizing of the emotional experience. With the deficit, it actually is represented as hyperarousal, impulsivity, association, symbolic behaviors such as cutting, purging, restricting, etc. Another area of deficit would be attribution. So that would be having complex and integrated schema. And to make this a little bit easier to understand, that would mean seeing, kind of holding conflict, holding opposite emotions together, seeing the good with the bad. In maladaptive processing, it would be more of polarized schema, or what one would say would be black or white thinking, all good or all bad. thinking is often it's referred to. And alterity is the third area, which is perspective taking. So being able to take perspective and see yourself and see another and see the difference between self and other needs, emotions is an example of that. So instead, often there will in the maladaptive network, there will be obsessive self-talk, feeling alienated or alone, isolated, or feeling too close or enmeshed in a relationship. And that would be the deficit that we are trying to address to build up a greater sense of alterity. So how DBP works, the higher level of emotional processing systems are not working well in the brains of suicidal individuals. This leads to hyperactivation of that amygdala fire alarm system, fight or flight system it's often referred to as well. And attempts to self-soothe are activated through maladaptive or destructive behaviors. Our model in DDP is it attempts to reverse a lifelong pattern of avoiding painful emotions through distraction, dissociation, substance abuse, and these areas can be very challenging in treatment. The individual is therefore given the freedom to choose topics or issues they want to explore or discuss, to give them a sense of openness and freedom to be themselves and be here without judgment, or the judgment-free zone, as you would say. So there's no bad choice, and through having this freedom, a person often gains a greater sense of themselves just by having that choice, as the therapist is not driving the topic. Most helpful is usually a focus on recent social interactions. So we keep it in here and now, practice identifying underlying emotions in the encounter. So we kind of like talk about how you're feeling in different parts of interactions that a person is presenting. So they would say how they felt during different parts of that interaction. And this would help to bring out the emotional experience rather than avoiding it or suppressing it, which leads to that higher level of risk. So who's a good fit for PHRP? Anyone struggling with thoughts of suicide, or have had current or recent or past suicidal gestures. Anyone ages 14 through 40. And anyone willing to try to talk through their difficulties and gain a greater sense of themselves. Who's not a good fit for PHRP? Anyone who's unwilling to really try and bring up topics to discuss and interactions to discuss. Anyone who's unwilling to commit to working toward health and recovery and committing to a life worth living. Anyone who has a mind so severely impaired by psychosis, drugs, developmental disabilities, or who's at an unhealthy low weight. So this would be below the recommended minimum body mass index. Because anyone who has severe enough deficits due to these issues will have disruption in the emotional processing centers of the brain that we're meaning to activate. High care coordination needs such as frequent CPS calls or active CPS case, anyone who has needs for SPOA, or anyone who has an IEP involving frequent meetings with the school, homelessness, etc., will likely indicate need for referral to an alternative program that can provide more direct attention to these areas of need. And that person can also, once they have more stabilization, can revisit the option of coming back to Psychiatry High Risk Program. But we have a very highly focused therapeutic approach. So these high areas of of need would not be able to be addressed in this model. I do want to thank you for your time and attention in considering our program. Please feel free to call our intake coordinator, Nicole, at 315-464-3117 if you have any further questions. Here's a list of resources, including a website for us to find out any additional information that you might have before you decide to apply. And there's some emergency hotline contacts included as well, if there are any needs to use them in crisis or if at risk. Again, thank you very much for your time and hope to hear from you